The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. In today's podcast, we're going to touch on another respiratory failure patient, again, surrounding the obstructive pathophysiology of the COPD patient. I keep seeing these types of cases and some decisions that are being made in some of these cases that have some complexity to them. And I really want to highlight some areas that we need to be very, very careful with when it comes to mechanical ventilation and our overall strategy. This is a 50-year-old male patient that arrives at a small outlying hospital by EMS for respiratory failure. He has a history of COPD. He's got a history of hypertension, past drug use, alcoholism, and he is non-compliant with medications. Seems to be admitted every few months, talking to his dad. And so this is a very repetitive thing that happens again every 2 or 3 months. He is trialed on BiPAP for about 12 hours and he finally becomes more obtunded, and they make the decision to intubate him and mechanically ventilate him. Flight crew is called to transfer him from this small outlying hospital to a higher level facility. He is 5 foot 10 inches tall. He's got a total body weight based on weighing with the bed at 300 pounds. So he's a bigger guy. He's got a big barrel chest. He has an 8.0 ET tube in place. It's confirmed with end-tidal CO2 waveform capnography. It is secured at 24 at the teeth. Arrival vital signs. Flight crew notes BP of 90/45. Heart rate of 120, SpO2 of 88%, and he has an end-tidal CO2 of 70 millimeters of mercury. He's got a good waveform. He definitely has a shark fin appearance to that waveform. ABG, they're given immediately on arrival. He's got a pH of 7.10. He's got a PaCO2 of 120. We'll go back and talk about that. Bicarb of 29 and a PaO2 of 165. So he has the classic ABG. He's got a partially compensated respiratory acidosis. And the reason why it's partially compensated is because that bicarb is elevated. It is more alkalotic. It is above that normal range. And that is a very common ABG when you have a chronic COPD. So it did not surprise me at all. PaCO2 of 165, again, did not surprise me based on that initial ABG. Arrival vent settings. This is what we noted. He had a VTE exhale tidal volume of only 240 mils. He had a rate set on the vent of 24 breaths per minute. He had an unvented vent circuit applied. So there was a massive leak happening. So that initially prompted the flight crew to escalate to moving over to the Hamilton T1 rapidly. Initial vent settings, they opted to match or closely match the settings. They didn't make some alterations. So they went with PSIMV plus on the Hamilton. They targeted a 6 mil per kilo tidal volume. That gave them about a 420 mil target. They set the rate of 18. Now, initial rate, as I said, was 24. Inspiratory pressure initially was set at 25. He had 5 of PEEP applied, and they get an immediate response of exhale tidal volumes around 280 mils. They set an ID ratio of 1:4, which when you do the math and you look at a rate of 18, ID ratio 1:4, that is only an I time of 0.75 seconds with an E time of 3 seconds. Their RCexp was 39. They have an RCexp of 1.4, definitely lengthened, and they have a static compliance of only 39 with an auto PEEP of 6. End-tidal CO2 immediately climbs to around 80 millimeters of mercury. Does still have a good pleth, but the shark fin appearance is definitely more well-defined. So let's actually have a little discussion. Let's just review, and I think this is really the key. we have to immediately identify what type of patient this is. Even though this patient has a history of COPD, doesn't mean we automatically go through the obstructive approach. We have to determine, does this patient truly, are they in the hospital currently in failure from COPD or asthma? And the answer is yes. So this patient needs to go down that obstructive approach pathway. And what does that mean? Well, we start with the same tidal volume range, 6 to 8 mils per kilo, but we have to be very, very quick to make the determination. Most often, remember, when you look at a chest x-ray of a COPD patient, these patients have hyperinflation. They have a flattened diaphragm. Their lung expansion, if you were to look truly at their static compliance is normally elevated. And so they are very well apt to handle an 8 mil per kilo, or maybe even a little higher in some cases, tidal volume. We want to always understand why we go obstructive approach or why we go injury approach on these patients. And it's about the protection of the approach. And remember, for review, the injury approach, the protection is to protect the lung from further injury. Well, this patient is not an injury approach patient. This is an obstructive approach patient. The protection is respiratory rate. This is the error I see made all the time. I've seen it made by respiratory therapists, and they'll set the rate high. Guys, you got to remember, when we set a rate high, your rate is your protection. The higher you set your rate, you're limiting the time interval to adjust I and E. And so if you have this high rate of 18, 20, 24 as the hospital had, and then you set an ID ratio of 1 to 4 and you start doing the math, your time interval is narrowed down extremely low. And if you spend all of that time in the exhalation phase, you end up with no inspiratory phase. And so I'm going to talk about why that's a problem. And I keep seeing this happen over and over and over. And why does this happen? Because we get tunnel vision. We look at that end-tidal CO2. And remember, going back to the ABG, that initial end-tidal CO2 was 70, I believe. And so we had an end-tidal CO2 of 70, but we had a PaCO2 on the ABG of 120. So we had a 50-point gradient between the two. Well, we see those numbers. Those numbers are alarming. Got to remember, we got to step back. Where does this individual likely live? They probably live hypercapnic. Don't know what that is. Could be 50, could be 60, somewhere probably in that range. They sit in this partially compensated respiratory acidosis all the time. That's why the bicarb is compensating. And so we have to be very, very cognizant and remember the knee-jerk reaction to these problems is, hey, if we give more rate, and from a basic standpoint, that seems to make sense. But if we give more rate, we're going to blow off more CO2, but we forget it's not about rate. And I can't stress that enough. It is about moving minute ventilation. And how can we do that? We do minute ventilation in two ways. We can either go a higher tidal volume and a lower rate, or we can go a higher rate and a lower tidal volume. And in this case, being an obstructive lung patient, this patient needs a wider range for the IDE ratio. And the only way to do that is to lower the rate. And so that is the protection. I can't stress that enough. Bring the rate down, increase the tidal volume. Again, they can handle that. And you will be amazed. You're doing the same thing. You just now have a wider window to adjust your IDE ratio. So what did they do? This patient was on about 25 mics of propofol. Patient had pain medications on board. Fentanyl, had a little bit of Ativan prior to our arrival. Patient became more hypotensive at that point, so we did start some norepinephrine. We evaluated volume response. Patient had very little volume in and out, so there was a bolus given at that point. So secondary adjustments, discussing this with the crew, made the determination to increase tidal volume to target an 8 mil per kilo. So we're targeting about 560 mils at that point, lowering the rate down to around 12. Inspiratory pressure was increased to 35. PEEP was dropped to 3. Now let's talk about that. Remember, on your Hamilton, on any vent for that matter, whether you're using a Revell, an LTV 1200, you have to know what your vent. If you have your Zoll vent, all vents have a high pressure alarm limit, and then that breath is terminated or stopped. Every vent is a little different. Hamilton will limit the breath at 10 below the high pressure alarm limit. So if you have a patient that has high respiratory resistance or inspiratory resistance, narrow airway caliber, and you have this need for a higher pressure to actually inflate the lung, but you're limiting that with a high pressure alarm that's set default at 35, meaning it will limit the breath at 25, you are never going to fill the lung, and you're going to be under volume every single time. Your VTEs will continuously be low. So I've seen this as well. Two things to look at. If your VTEs are not coming back adequate, number one, make sure you take your high pressure alarm out of the equation. Remember, and this comes from Scott Weingard, multiple pulmonary docs, our medical director, Mike Loria. You know that this patient has a high inspiratory resistance. You know they have a high PIP. Ultimately, though, you have to ventilate the lung. That's the key. So in this example, we're not talking about a lung injury patient. We're not talking about somebody that has to, we have to focus on plateau pressures or lowering driving pressures, right? Completely different type of patient. We want to ventilate the lung. We want to fill the lung. You have to overcome that resistance. So that means you need to take that out of the equation and get to a pressure that allows you enough pressure to move through all that resistance, right? And then you're going to start seeing that volume increase. Number two, as I talked about, what happens if you start lengthening the E time out? You are moving. I always think of a horizontal line, and I always think of, I've got a bar somewhere in that line. We'll say we're dividing it by a third, and that first third is your I time. The rest of it is E time. And all I can do, if I want to lengthen my E time, I'm moving my bar towards the left. I'm shortening my I time. Well, if you are focusing on getting that E time lengthened even more, you're going to shorten the inspiratory time. At some point, though, you have to translate this, and I've said this many times on other podcasts. You have to translate this. Are you giving enough time to fill the lung? If you're trying to fill the lung with 500-600 mils of total tidal volume, and you only have a half second to do that, or 3/4 of a second to do that, think about what has to happen. Your pressure has to be exceedingly high, and think about the flow requirements and how that velocity causes these high pressures. And so just by doing that, you're causing increased PIP greater than what would otherwise be seen in other settings. So always evaluate. And I think that we've talked about this in other podcasts. A 1-to-4 ID ratio is a great starting point. And so that is what this crew did. So they went with an inspiratory pressure of 35, a PEEP of 3. So their overall PIP, just starting out of the gate, is 38. ID ratio 1-to-4. And if we do the math, that gives us now a 1-second I time. So we've increased our I time a little bit more, and a 4-second E time. Inspiratory resistance did not change. It stayed around 39. RCexp dropped to 1.2. Static compliance actually increased. So I want to touch on that. Something I've seen again over and over and over is static compliance. We should know, and if you've taken our Art of Ventilation course, I really dive into this in great detail, but we should look at the parameters on the Hamilton very, very specifically. Monitoring tab 3 has so much valuable information. Really, you can make a lot of decisions based on that, but those decisions should be confirmatory decisions. They should be confirming your clinical suspicion, your differential. They should not be aha moments, meaning I should automatically know that in most cases, COPD asthma patients' obstructive lung pathophysiology will elicit a high resistance. It will also elicit a high compliance, meaning these patients have really good compliance. They have elastic lungs. They're also going to often be on the higher end on the RCexp, which remember is your expiratory time constant. All you got to do is take that number, multiply it by 3, and that should be around where your exhalation time should be. It's very, very simple. So if we're 1.2 times 3, that should be my expiratory phase, which is around 3.6 seconds. And if we use that to adjust our ID ratio, we can fine tune that phase. So the static compliance, back to that area, if you are underventilating the lung and you're barely inflating the lung because maybe your I time's too short, maybe you're not, you're limiting the breath from the standpoint of your overall high pressure alarm, and you're barely filling the lung, the static compliance is going to reflect on the lower end. So what I always say is make sure you're getting adequate tidal volumes to match their ideal body weight based on that target of 6 to 8 mils per kilo before you look at your static compliance and really identify, is this what it should be? Again, in most obstructive lung pathophysiology, you're going to have good compliance, high compliance. In ARDS, on the opposite side, you're going to have low compliance. You're going to have a stiff lung. So those should not be surprises. And so for this patient, if you remember, that initial static compliance was really low, but we were barely inflating the lung. Once we were able to get tidal volumes up into more of a normal range for this individual, the static compliance increased to what it should be. There was now a third adjustment. So this was a constant fine tuning. And what we found is this gentleman, and I did this podcast with Mike Loria last month, where we talked about transpulmonary pressures and the weight of the chest and the impact on those pressures inside the lung. Some patients, because of how heavy they are, if they've got this big, heavy barrel chest, if they have some obesity, they might automatically need higher pressures or like bigger volumes just to fill the lung. And what we found with this gentleman is that he liked volumes between 660 and 690. Now, that was definitely a greater amount than 8 mils per kilo. Rate of 12, but that's where we really found the sweet spot. And what we found is we were seeing a drop in the need for inspiratory pressure. So we were able to drop the inspiratory pressure to 30, kept the PEEP at 3, and we also switched to a 1-to-1 ID ratio. We found that, hey, we need a longer phase. If our volumes, he likes bigger volumes, we need a little bit longer phase. So we went to a 1-to-1 ratio at a rate of 12. So that's 5 seconds total respiratory cycle time divided by 2. So that means we have 2.5 seconds in, 2.5 seconds out. And that really did start improving things. His RCEMS, his resistance dropped to 35. His RCexp stayed around 1.1, 1.2. Static compliance came up to 77. And auto PEEP stayed around 3. Blood pressure stayed right around 88 over 45. Went up to around 15 mics of norepinephrine, which would equate to right around 0.1 mics per kilo per minute, in that range. Heart rate of 110, SpO2 91% at this point, and end-tidal CO2 was down to 65. So I think, the highlight here, guys, is remember, it is really, really easy to focus on an end-tidal CO2. And look at that number and try to chase that number. And this is no different than what we discussed in other podcasts, where we try to bring an end-tidal CO2 up that's low in maybe a partially compensated metabolic acidosis patient, right? We always want to look at the underlying reason why somebody's end-tidal CO2 is altered. Rate is your silent killer. And what I mean by that is, remember, the obstructive pathophysiology, the obstructive approach is all about protection. Keep the rate low. My personal belief is I like to keep that rate at 10 for that adult patient. Makes the math really easy. Gives me a 6-second cycle time. If I want to go to a 1-to-1 ratio, I have 3 second in, 3 second out. I can adjust my range a little bit better at a rate of 10. And I think this gentleman would have done fine at a rate of 10. High rates lead to this disaster with your ID ratios. And that's what I keep seeing is we, again, forget. We get so focused in on the end-tidal CO2 and we chase it with the rate. If we have a high rate, remember it gives you almost no inspiratory phase because you're trying to spend the entire time in the expiratory phase. That's going to limit your ability to fill the lung, and you're going to have an overall difficult time getting any adequate VTEs, which is going to cause a big drop in overall minute ventilation. And so again, remember the big picture. It's not chasing end-tidal CO2. It's not raising the rate to try to drop it. It's about optimizing moving minute ventilation in and out. That's the key. And remember, it's not just exhalation. These patients have inspiratory failure as well. So you have to focus on the inspiratory side and the expiratory side equally in many of these cases. A low rate is your best friend. I can't stress that enough. It gives you so much ability to work within the confines of this obstructive approach to really optimize ID ratio. And when you, again, see a low VTE, alarm bell should go off. Immediately, alarm bell should go off and say, number one, is my high pressure alarm limiting my breath? Number two, is my I time too short? And that is the key to say, hey, I want to make sure my rate is dropped down. I want to make sure that my ID ratio is what it should be. And that's the other thing I would challenge everybody listening to this podcast. A lot of times when I do education, I'll ask the provider, well, how do you calculate ID ratio? Like what is the math behind the ID ratio? If you have an ID ratio of 1 to 4 and you have a rate of 10, do you know the numbers behind that? And it's really, really simple. You take the respiratory cycle time. So however my rate is, I have 10 breaths per minute. I divide that into 60 seconds. So I know I have 6 seconds. Every 6 seconds, I'm going to breathe in and out. I'm then going to say, well, what's my ratio? My ratio is 1 to 4. So I take 1 plus 4 equals 5 parts, and I divide that into that 6 seconds. And that's going to give you your I time. And that equates to 1.2 seconds. The remainder of that total cycle time is your E time. So I'd have 1.2 seconds in, 4.8 seconds out. The common answer I get from crews is, well, I don't know how to do that. I just look at my ventilator. But if you don't know the math behind what you're doing, you're truly, in these cases, these critical cases, you are not going to be able to make good decisions and understand the big picture of why you might have a problem. Again, if you're able to look at that and go, man, I only have 0.6 of a second to inflate this lung. Well, maybe that is why, because my resistance is so high. My airway caliber is so narrow. I'm trying to force all this pressure through this narrow cavity. What's going to happen is going to drive up inspiratory pressures. That turbulent flow causes issues, and you're not going to have enough time. It's like trying to fill a balloon through a stir straw. If I said, put a stir straw in a balloon, and you try to fill that balloon in a half second with 500 mils of volume, I promise you it's impossible. The only thing that could happen is you have to increase that pressure to these exorbitant amounts to even do that, and that is unsafe. So remember, guys, it's all about understanding the obstructive approach. Respiratory rate is your absolute friend. It's your protection. Keep that rate low. If you're dealing with pediatrics, I would lower the rate from a standard rate by probably 4 to 6 breaths per minute. But again, it gives you this wide ability to adjust I to E. Don't get focused in on that rate driving down the end-tidal CO2. Focus on the big picture, which is minute ventilation. That is absolutely the number one focus point on these patients. As always, if you have any questions, please email me, eric.bauer@flightbridgeed.com. If you have any cases like this that you want to discuss, please shoot them my way, and we will talk to you soon.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.